So thank you all for joining today. I'm James Konopik with the North Dakota Department of Health and Human Services, and I'm specifically within the Behavioral Health Division. And my role with the Behavioral Health Division is I oversee the licensing of addiction treatment programs throughout the state, as well as opioid treatment programs. And then I also oversee our opioid initiatives and our prevention initiatives in the state. And so with that, I'm just going to share my screen here really quick. So just give me a moment. All right. And I'm hoping that today I can offer a overview of how to access behavioral healthcare services in the state. And with that, I really want to focus specifically on addiction treatment services, mental health services, and then
Well, just
crisis
ask me.
behavioral health services. So jumping in here, I just want to quickly talk about what is behavioral health and give a little background on the behavioral health division. So first of all, we see behavioral health as a state of emotional and mental well-being, and that includes choices, actions that impact an individual's overall wellness. And so this encompasses the full continuum of care, which is broader than just the treatment slice of the continuum of care. It includes the promotion of overall well-being. It includes preventing substance use disorders and mental health disorders. It includes the treatment of those disorders. And it also includes supporting recovery from behavioral health conditions as well. And in North Dakota, it's important to identify that brain injury is also considered to be a behavioral health condition. So just want to throw that in there as well. So one of the main things is to recognize behavioral health is a part of health. Behavioral health is health. So there is the intention that behavioral health care is treated on an equal footing as traditional health care. And so just that recognition that there should be parity between behavioral health as well as physical health. And then I briefly talked about that continuum of care. Our goal within the state is to ensure that all aspects of the continuum of care have adequate services available. So it's not replacing treatment with prevention or prevention with recovery. It's really supporting that full continuum of care. And then last slide that talk a little bit about the behavioral health division. So in North Dakota Century Code, so in state law, is where we receive our authority to do things within the state. And those include making sure that there are services available to individuals in need, ensuring quality standards, and then also ensuring that services are provided in a way that ensures individuals' health and safety are taken into consideration. And then we have a few overall goals in our behavioral health division. So our three primary objectives right now are to ensure that the full continuum of care is being supported, to increase access to community-based behavioral health care services so that people can have services closer to home, and then preventing the criminalization of individuals with a behavioral health condition. So with that, I just want to quickly talk about what some of the overview of principles of care are in the behavioral health realm. So one of the primary things to know and think about is care should be person-centered. And so what this means, I found a really great quote from SAMHSA, so our federal government. They talk about person-centered care is the effort to ensure that mental health care is centered on the needs and desires of the consumer. It means that consumers can set their own goals and they have choices in the services they receive, and they can select their own recovery support team. Mental health providers who are persons with person-centered care means assisting consumers in achieving goals that are personally meaningful. And so really what this does is it puts the individual at the forefront. So individuals should be involved in all aspects of behavioral health care, from assessment to treatment planning to discharge decisions and ongoing care as needed. So it's really having that person be at the forefront in their healthcare decisions. Some of the principles of person-centered care are that transparency, having individuals know what their treatment plan is, supporting all aspects of an individual, and then making sure that those interventions that are being used are things that specifically impact an individual and considers that whole person. So treating an individual with respect and dignity really is at the forefront of behavioral health care. And then a couple more things on person-centered care. So there should be agreement. This is between treatment providers, supportive agencies, and the individual on what the goals are, what the tasks are, who's going to participate in the care, and what are those individuals' roles who are participating in the care. And as a result of utilizing person-centered care, the relationship between the individual and the provider should be seen as something that is collaborative. So it gives that sense of the provider is being empathetic towards me. It should be viewed as being respectful, and that creates that trust between the individual and the provider. It gives an individual a sense of understanding, which leads to that hope. And then it should be encouraging, which empowers the individual to know they can make changes in their life and they do have an involvement and a responsibility in their treatment. So just have a couple of slides here to show some of the old school traditional approaches to behavioral health care with how substituting that in a person-directed or person-centered care approach would look. So a couple of things I'll just focus on. One of them on here is that expectations are set very low in a traditional approach. But in a person-directed approach, there's actually really high expectations. So one of the things I forgot to share as I started here is my background is a licensed addiction counselor. And when I first got into the field of addiction counseling 15 years ago, one of the things I would hear in treatment groups is this statistic, and I don't know how true or made up it was, that only 10% of individuals who go through treatment are going to, and I'm going to put up air quotes, remain sober or get clean. That's really low expectations. How could you start off a treatment group and tell people there's only a 10% chance you're going to have any success from this? I know if I went to my healthcare provider and I have high blood pressure and they say there's only a 10% chance this medication is going to work for you, I don't think I would have a very high likelihood that I'm going to follow through with their recommendations. And I probably am going to go look for another provider who has more confidence in the care they're going to offer me. So with person-directed care, it really is, we're going to set high expectations, but we're going to make sure those expectations, those goals are things that you actually want to accomplish. So the focus is not on the illness, the focus is more on wellness. The focus is not on how do we reduce symptoms. The focus is on how do we increase functioning. So I just want to point out that spin on how to make things more positive using person-centered care. So again, continuing on with this, the traditional approaches oftentimes only focus on professionals being involved in a treatment plan, where we know that an individual's treatment really should consist of their full support system and kind of more that wraparound treatment. So that may include family members, that may include friends, that may include paraprofessionals, that may include peer support specialists. But there is a whole bank of individuals that we can rely on to assist in the treatment and recovery process that oftentimes are undervalued or are not thought about. So again, these are just some of those characteristics of person-centered care. Another principle of care I want to point out that is often a misnomer, especially in addiction treatment, is that thought that somebody has to actively seek out treatment for it to be effective. So there is, and I should have put the source up here, but this is also from SAMHSA, but treatment does not need to be voluntary to be effective. So even if an individual is prompted to seek some sort of behavioral health care treatment, whether there's a prompt from a legal system or a probation officer or whatever that external drive is, that individual can still experience gains and success and find that they're able to meet their goals in treatment and recovery. So now I just want to dive into how do you actually seek out those different types of services that are available in the state. And with that, so starting with addiction treatment, I just want to give a broad overview of how addiction treatment is framed throughout most of the country and in particular here in North Dakota. So the American Society of Addiction Medicine is where we get our standards for what different treatment programs should look like. They're broken apart on a scale with a numbering system. So the lower numbers are less intensive levels of treatment, and the higher numbers are higher intensities of treatment. So the broad categories are a 0.5 level of care, meaning it is an early intervention strategy. So it's not in that realm of treatment yet. The level 1 services are outpatient. Then level 2 are more intensive outpatient programs, leading up to level 3 programs, which are residential settings. So this is more often what individuals think of when they think of addiction treatment is somebody going off to a 28-day program. So thinking about the Sandra Bullock movie, that's more of what that level consists of. And then level 4 being like a medically monitored acute psychiatric hospital, maybe. So just trying to point out here that there are broad categories for treatment. Treatment does not necessarily consist of just a 28-day residential setting, you get out and everything is fixed. There's actually fluid levels of care, and individuals should be able to transition through those levels based on what their individual needs are. So with that little bit of background, just want to point out that in North Dakota, we have 104 licensed addiction treatment programs. This statistic is actually from January of 2020, or 2021, excuse me. So this was right before the last legislative session that pulled this map. So this is just slightly outdated, but I do know that we have a few more licensed programs than we did at this point. So throughout the state, there's over 100 different providers who offer addiction treatment services. And what they offer can vary from those levels of care. But I just want to point out that every region in the state has some licensed addiction treatment programs that exist. Now, that doesn't mean that there's a residential setting in every region, but it does mean that there are services available in every region. And again, that might range on that low intensity outpatient, higher intensity outpatient, but there are services available in all the regions. There also are certified DUI instructors and MIP instructors in the state. I know that there is at least one DUI and MIP instructor who is located in each region in the state, and those are also certified by us at the Behavioral Health Division. And again, those early intervention instructors are more geared towards somebody who does not yet have a diagnosis of a substance use disorder. So if somebody is at risk of developing a substance use disorder, they would be appropriate for more of that early intervention than an actual treatment program. So moving along, and I do have some slides about how to actually look these programs up, so I'll be circling back to that here. But we do have 4 opioid treatment programs that exist in the state as well. There's one in Minot, one in Grand Forks, one in Fargo, and one in Bismarck. And what makes these programs different than the other addiction treatment programs is opioid treatment programs are the only programs that can provide methadone treatment to an individual who has an opioid use disorder. We know with opioid use disorder, best practice is that an individual would receive a medication for their opioid use disorder in conjunction with behavioral health counseling. And all of these 4 opioid treatment programs provide medication, and they also provide counseling. So this is where somebody can obtain any of those medications that are FDA approved for opioid use disorder. And then, like I said, they also have the counseling available at the program. And here I have, so here's the website on our Health and Human Services website, and I do have a link at the top of this page as well as the actual written out URL website. So going to this website is where you can access a list of all of the licensed addiction treatment programs in the state. On this list, you'll be able to click on that orange box, and I took a few screenshots just to kind of show you how this works out. But clicking on this orange box will give you a comprehensive list of all of those 104 licensed programs. Well, a little more than that now throughout the state. And then it will show their location, how to access them, their contact information, and the levels of care that they provide. Underneath this, we do have links if you want to search for just a specific level of care, who all of those licensed providers are. So that is a separate way that you can search for them on our behavioral health website. And then just want to show you, here's an example of what kind of information you'll find if you try to pull that up and look for programs. So just pulled out an example here. So it just shows you name of the provider, what their contact information is, and then their levels of care that they are licensed to provide as well. All right. So then the last thing, or the next thing I wanted to talk about is office-based opioid treatment. So this is actually prescribers who are able to prescribe buprenorphine or Suboxone throughout the state. So with Suboxone or buprenorphine, medical providers have to be registered with the DEA to be able to prescribe this, but they don't necessarily have to require that an individual follow through with addiction counseling as well. So again, that best practice would be somebody receives medication and counseling. So I just want to point out that these office-based opioid treatment programs may or may not have relationships with the addiction treatment providers in their area to make sure that individuals have access to counseling as well. But on this website is where you'd be able to search to find who are those OBOTs or office-based opioid treatment prescribers in the state. And then here, I just want to show a little map of where those prescribers are located. So this is broken down by zip code. The orange areas show where there's a zip code that contains both a prescriber who can prescribe buprenorphine, as well as a pharmacy that keeps Suboxone on hand. The blue zip code areas have just a pharmacy that contains buprenorphine. And then the green zip codes are locations where there's just a prescriber, but there's not a pharmacy in that same zip code that has buprenorphine on hand. So again, as you can see, just looking at the map, there's a lot of work we still have to do in the state to make sure there is equitable access to medication-assisted treatment for opioid use disorders. But on the same token, there are locations where you can seek care, and hopefully you'll be able to connect with individuals close to where you live and develop those relationships on finding out how to get an individual into treatment with an OBOT. All right, and then I also want to bring and highlight some information about youth residential addiction treatment. The reason that I want to call this out is there's one provider in the state who will accept adolescents with a substance use disorder into residential treatment. There's other residential settings that also will take individuals who are adolescents with a substance use disorder, but Eckert Youth Homes in Williston is the statewide provider who is able to accept any adolescent, regardless of their funding or ability to pay for treatment, to come receive addiction treatment at a residential setting. So I just want to highlight that one. And then I also want to highlight where to find gambling disorder treatment. So in the DSM, substance use disorder is recognized as a diagnosable behavioral health condition. And the one behavioral addiction that is also recognized in the DSM as a diagnosable disorder is gambling use disorder. In North Dakota, we have a program, our Gambler ND program, or Gambler Choice. There's a website on here and a phone number where you can call and receive information to get an individual into counseling for a gambling use disorder. So just want to call that out as well. And then I also want to point out that in the state, we have funding available for individuals who may not have any money or insurance to pay for addiction treatment through a program called the Substance Use Disorder Voucher Program. So certain providers are able to apply and become accepted as a substance use disorder voucher provider. Those providers then will take individuals who apply and are accepted on the voucher program, and will use the voucher funding in lieu of any other source of billing an individual for their treatment. So I just want to point that out, and then I do have a link here in this slide as well. Okay, so with that, I'll transition into finding mental health services. So one of the things I want to point out is the Behavioral Health Division, we license addiction treatment programs in the state because we have authority from our state legislature to do that, to make sure there is a minimum quality standard that those addiction treatment providers are meeting when they offer services. We do not have that same regulatory relationship with mental health providers in the state. So individuals who provide mental health services are licensed only under their individual professional license, and they are not licensed as a program by any state entity. So on this slide here, you can see there's professional counselors, marriage and family therapists, social workers. They are all licensed just by their individual licenses and not by a program level license. So this last legislative session, our behavioral health division received authority that we could create a registry to track all of the mental health programs that exist in the state. So this would be all of the clinics that offer mental health care in the state. So at this website, it's a really easy website to navigate. You can search by programs that offer adults services or services for children. And then you're able to select any of the criteria you'd like to search for. So if you just want to search for providers in your area, so just the mental health providers in Grand Forks, you could pop that up and just search for that area. You could search for providers who offer telehealth services. Like I said, it's a really easy directory to use, but this is a great way to find out who are those mental health providers in your area. And then I also want to call out the North Dakota Brain Injury Network. So on the ndbin.org website is the way that you can search for resources and services for individuals who have a brain injury or family members, individuals who might be struggling with a family member or loved one who has a brain injury. This is a great resource to know about if you're ever searching for brain injury services. All right, and then the last type of service I wanted to call out was crisis behavioral services. So nationwide, there was a recent rollout of the 988 behavioral health crisis hotline, which is a nationwide 3-digit number that you can call to access support for any type of behavioral health crisis. This is a phone line that's answered 24/7. It can be confidential if needed, and it could be anything from the range of I need help finding a counselor, or I'm feeling sad, or all the way up to I'm actively suicidal, or I have a loved one who is suicidal. When this phone line is called, a trained crisis intervention specialist will take the call, and then they can determine those next steps if it's something that can be resolved easily over the phone, or if it's something that would require a mobile crisis counselor to come respond to. Right now in North Dakota, we have crisis services, mobile crisis services available within a 45-mile radius of each of the 8 largest towns in North Dakota. So Williston, Minot, Devils Lake, Grand Forks, Fargo, Jamestown, Bismarck, and Dickinson. And those are operated by the human service centers in each of those regions. So again, that's 24/7 availability to call and talk to an individual, and potentially could result in a mobile crisis team responding if it's at that level. But again, this is a great way to get that crisis care when it's not something that requires urgent need, urgent response. So again, I just would want to point out that with each of these services, I'd really encourage you to look at those lists, look at the mental health directory, look at the addiction treatment provider list, and identify who those individuals are or who those providers are in your region, so that you can learn who to contact when you have an individual you're working with in need of service. So that would be the best way to start, is identifying who are those local providers and start building those relationships. Most of the programs are going to have some form of screening and then evaluation that they would require to have an individual start services. And that's really so that they can determine what is the most appropriate level of care and work with that individual on getting them admitted into that level of care, whether that's outpatient, residential, etc. So then the last thing I have here is just a quick case presentation, and I just really want to highlight how some of that behavioral health care and person-centered practices can work. So here, I just have an example of William is a 24-year-old Caucasian male with an opioid use disorder that he's had since age 16, as well as a depressive disorder since age 14. And then he discloses that he has a history of intravenous heroin use since the age of 19. So in this case presentation, William entered into substance use disorder treatment 6 weeks ago. He was in the high intensity residential care for 12 days. Then he participated in partial hospitalization, which is an outpatient level of care for 14 days, and then was currently in ASAM level 2.1, which is intensive outpatient. While he was in residential care, he received buprenorphine, so medication for his opioid use disorder, as well as an SSRI for depression, and completed a physical and testing for Hep C. Then he stopped showing up to intensive outpatient treatment. So with this, in this scenario, he hasn't had any contact with his addiction treatment provider for 2 weeks, but he shows up to his public health clinic requesting to be tested for hepatitis C, and he discloses that he has used intravenously 3 times in the last week, and on each occasion, he's shared a syringe with a peer. So in this, a person-centered approach would be, let's talk to this individual about what you would want to do. Here, he's indicating he wants to get back on his buprenorphine medication. He wants to stop his outpatient group because he doesn't like it. And he wants to talk to his counselor on an individual basis. So some ways to support this individual might be assisting with that warm handoff to call his prescriber so that he can get back on that medication, calling his treatment provider to see if he can arrange those individual sessions, making some arrangements to receive the Hep C testing, and then providing him with naloxone to help reverse an opioid overdose in case that would be something that occurs. So again, just making sure that that approach is not a you have to go back to residential treatment. I'm going to call your prescriber and tell them that you've been using heroin and you need to get off of your buprenorphine medication. It really is the person-centered approach is seeing what are you willing to do? How can we meet you where you're at and support you? So just want to kind of highlight how that could look. All right. So with that, I could take any questions, or I can turn it over to Lindsay here. And yeah, if there are any questions, I'd be happy to answer them, or you can definitely follow up with me if there's anything specific you'd want to talk about.
Well, thank you so much, James. I do have some questions. I think I'll save them for the end too, because they might blend kind of together with what we're going to talk about. So my name is Lindsay Vanderbush. I'm the director of the Sexually Transmitted and Bloodborne Disease Unit, which is in the Division of Public Health within the Department of Health and Human Services. I don't quite have all that yet, but I know that'll start to roll a little easier as we move on. So some things, there's a lot of things that we could talk about in terms of, you know, what we do for HIV, STI, and hepatitis, prevention care, and all those blended things. But we really just wanted to focus this presentation on kind of what we at the Department of Health and Human Services in the Division of Public Health can offer in terms of our testing services, testing recommendations, and kind of some of the care services that we have for people who may be experiencing some of these infections. So just kind of to go over the topics again that we'll talk about today, we'll kind of just go into some general screening recommendations, you know, who should be screened for infectious disease, kind of what time frame we recommend screening for those individuals, and just kind of some other more kind of unique things. We'll talk about one of our programs that we have. It's kind of one of our larger programs. It's called the Counseling, Testing, and Referral Program, or we shorten it to CTR. And that's a federally funded program through CDC, and then also augmented with some state funding to provide access to free, confidential, rapid, and then confirmatory HIV and hepatitis C testing. And how some agencies also couple that with STI testing as well, some other STI testing options. And then a program that we've rolled out over this last year is really trying to bring services to people in a place and location where they are. And that's with our home test collection. So as you're kind of working through with, some of your patients as well, who may be in an outpatient setting, or you're working with them in a telemedicine setting, home HIV and hepatitis, or HIV and STI testing and other things, may be something that you could incorporate into your practice as a behavioral health professional to kind of meet that need that patient may have. Then we'll just go over some general HIV prevention and care things and resources, especially if you are interacting with a patient who has HIV infection. We have a very robust program within the state to ensure that people have access to comprehensive care services. A little bit about hepatitis C treatment. Not gonna lie, it's not great out there for hepatitis C, but we're trying really hard to make that better. And then some other resources for you. So this slide is just kind of in here too for you all to kind of just take a look at, and it really ends up being kind of complex when you're really taking a look at it. But I think what it really boils down to is that a lot of times when people are, interacting with healthcare for a variety of reasons, or behavioral health care, it's potentially often that someone's sexual health or their sexual health practices could get kind of missed or fall through the cracks. We see kind of time and time again where there are a lot of missed opportunities for people who kind of fall into these different categories, who are seeking care either at a primary care or through other treatment services that are either kind of never assessed for these kinds of services and then ultimately aren't receiving them. Sexual health is something that people are tend to be more closed off with, just as they are possibly with their mental health and other behavioral health needs. But it's definitely something that needs to be kind of part of that comprehensive conversation, since we do find that a number of folks that we then diagnosed with chlamydia, gonorrhea, syphilis also report substance use and other behavioral health needs. So we do know that oftentimes people in those populations could be at higher risk. Not going to read this to you, definitely can read this as well, but just kind of wanted to provide this as a snapshot too, that, on average, people who are younger, people who are sexually active, people who have more than one sex partner should be screened at least once a year at a minimum. Pregnant women obviously should be screened for not only chlamydia and gonorrhea, but other infections with each pregnancy, and dependent on, their sex practices, maybe more often, just because we know that there's intervention that we can do before that child may be born to prevent any further infection. Men who have sex with men, we don't generally utilize the term like gay man or anything like that, because we find that there's a lot of people who would never identify in those ways. But so we really try to take a look at people's gender identity and their sexual practices as we're kind of making some of these screening recommendations. So that's why we utilize that term. We get asked that kind of quite a bit. One thing I should highlight though, as well, kind of with all of these things, is that there's also kind of a next step that kind of happens with chlamydia and gonorrhea screening if you plan to incorporate it into your practice. Generally we find that people are kind of screened either through their urine or through a vaginal specimen, but that may not be kind of what they would need. So a comprehensive sexual health assessment of the type of sex that people are having is really crucial to assuring that you're providing that comprehensive service to somebody who may be at risk for an STI. We routinely find that, for people who only have receptive anal sex, if they're tested with their urine, you're not going to be finding these infections and you'd be missing an opportunity to get someone treated for chlamydia or gonorrhea. Another thing of note, just kind of want to highlight as well, syphilis used to be a kind of very rare disease. It used to be something that we did not see very often, or we would get reports of people with, very old or latent syphilis, but it has definitely kind of taken hold in the United States in most recent years. Kind of one of the more severe outcomes of syphilis would be congenital syphilis, or that would be a baby born to a mother with active syphilis infection. We weren't able to either provide the appropriate treatment before delivery, or the infection wasn't found until at delivery or after the child was born. For this, and many of you may not deal with prenatal care or things like that, but if there's anybody, that would watch this too, who works in an emergency department setting or is, working with people who are pregnant, the follow-up and the prenatal care is essential to reducing these ongoing congenital syphilis cases. We hadn't had a congenital syphilis case in years. And we have had 5 over the last couple of years since January of 2020. Many of these were in women who had substance use issues, who had other kind of justice involved issues, were not really interacting with healthcare, but then also women who did not have any thought that they were at risk. So it's also, again, it's important to do the screening of individuals who may not appear on the surface to be at risk for infection, especially when you're not always sure or knowledgeable about the sex practices of their sex partners. So we do recommend for pregnant women that there are 3 screens during pregnancy in all circumstances. That's become a standard of practice of many birthing facilities across the state, which we're really happy about. But then also too, for people who are having a lot of sex, it's just important for screening to kind of happen, for folks to watch for kind of some of the signs and symptoms of syphilis, which can be very varying, I guess. So yeah, these are kind of some of the recommendations that we have for syphilis, and really are looking for more opportunities for the incorporation of syphilis testing just into general STI screening, as it is recurring in the nation. One other kind of general recommendation is that everybody, regardless of risk, be screened at least one time during their life between the ages of 13 and 64. It's just a general baseline screening for people to kind of know their status, and then additional screening to be recommended based on other risk factors that may happen over the course of a person's life. So again, recommended universal screening. This also holds true for hepatitis C. There's a general universal screening recommendation for that as well. And without kind of this ongoing screening of persons, we really kind of won't get ahead of HIV in kind of some really meaningful ways. So it's very important that providers and people at any opportunity to interact with people in the healthcare setting are kind of thinking about these types of preventative health screenings. This is just an infographic here about HIV in the United States. It's a little bit older, but it kind of still holds true that, even in the United States where we have access to care and treatment, not everybody is always in a place where they can really manage their HIV infection as well. Many other coexisting factors may exist. And so, we are committed here in North Dakota, and I'll kind of talk about it a little bit later, to assuring that we can really provide a comprehensive service to people who are living with HIV, not only for their medical care, but their whole person care, kind of like what James talked about before, thinking about the person and their individual needs. Ultimately, one of our best prevention tools that we have for HIV is early diagnosis and viral suppression of people who are infected. So I know that this number is coming up in the United States as we're doing better at meeting and achieving viral suppression. But if you hear that term, viral suppression, a person who has HIV, who is on medication and has achieved and sustained an undetectable viral load, they have no risk of transmitting their infection onto another person sexually. And the risk, they're still studying it, but the risk through injection drug use or other bloodborne means is drastically reduced as well. And so really HIV diagnosis and linkage to care and ultimately achieving viral suppression is one of our best tools in our toolbox that we have to kind of stopping that chain of transmission from other individuals. But that diagnosis piece can be tricky. And so assuring that we have access to all of those testing resources in any place or location is really paramount here. So like I said, too, hepatitis C screening is recommended for basically all US adults to be screened at least once during their life. Pregnant women is now kind of a standard practice to screen for hepatitis C during each pregnancy. And so that's, as with HIV, as with other STIs, that is something that's becoming a part of that general routine prenatal kind of workup. Other people who are at risk for hepatitis C, include people who have ever shared blood or blood product, not necessarily blood products in a medical setting, but who are sharing blood, I guess, with other persons. We do see a high proportion of our new infections. The people who are under 35 do report injecting drugs as their primary risk factor. That's been kind of present for many years now. So we just know that risk is very high in a population that we all are both really trying to serve in two ways. One, through hepatitis C knowledge of infection and or prevention, as well as for substance use treatment. The reason why the prenatal screening is really kind of starting is that children who are born to mothers with infection do kind of have, the risk is not absolute that child will be infected with hepatitis C, but if the child is found to have hepatitis C, ensuring that child has access to care and curative treatments is important to assuring that as they grow, that there aren't ongoing sequelae with that. The one beautiful thing about hepatitis C in kind of recent times is it is curable. So we do have therapies that are tolerated and well managed by people that can cure them of this infection. So knowledge is first, and then linking to people to cure is the next step. So I'll just talk a little bit about, again, our CTR programs, and I'm going to watch time here. I'm running out of it. Our CTR program, we offer free, again, HIV and hepatitis C rapid testing, and then a reflex to confirmatory testing for people who are at risk for HIV. We have many different settings and clinic types and organizations that we work with across the state. Our syringe service centers all have access to these services, many local health departments, community health centers. We also partner with correctional settings to offer testing as well. And we're always open to new partnerships, be that either in MOU or grant funded kind of opportunities. And if anybody's interested in knowing where those locations are, they can be found here. Many of these organizations too are also open to collaboration. So if you have a behavioral health service in a town and are thinking about these types of services, you can take a look at this map and reach out to some of your CTR providers in your area, as they may be interested in doing some collaboration with you as well. I know many have done that. It's a good way to bridge those services without maybe needing to incorporate them into your practice. But it is kind of a very essential service for many people who are seeking out substance use needs, as these risks may also be present. Just kind of for the sake of time, STI testing is one of those things that we are just not funded to provide. Our federal grants do not offer us funding to actually provide testing. Our grants are for surveillance, and our grants are for providing education to healthcare providers. So this is a real gap that we do have in North Dakota, but there are a number of other locations that get really creative on how they can offer really cheap and reduce really low cost and or sometimes free STI testing. One great partner are family planning locations who do offer a sliding fee scale to anybody who would need an STI testing service. One way that we are kind of doing it is through this program as well. I kind of alluded to it a little bit before. This is a program that we initiated earlier this year, and it is a complete kind of from this location to a individual service. So if you would go to this website, you can do a risk assessment. It would indicate for that particular individual, based on the risks that they may have, what kind of testing would be most appropriate for them. They would receive a kit to their home. It's kind of comes in a really nondescript kind of box. At their own leisure, they're able to collect their own specimens. Blood spot is all done on like a blood spot card, kind of like when you do like for heel sticks and things like that. And then that all can just from their home be sent back to an actual laboratory. These aren't like rapid tests that are done in home where people need to then kind of digest those results. These are all sent back to a laboratory. And then we have a clinician that meets with people via telemedicine to kind of, go through the results and talk through some prevention tools and things like that. So we're really excited about this program too, and kind of want to get the word out. We were a little bit trepidatious at first to kind of roll it out like statewide. There was another state that did that and they ran out of money for their program in 2 weeks. So we've been really kind of rolling it out in a way that we're trying to get it into the eyes of people who could benefit from it the most, to kind of conserve some of those, some of our needs. But this has been a really great program, and Jennifer Schmidt, who's on here too, who's part of Building Bridges, is the kind of the coordinator of this program. So if you have any questions, you can reach out to her. Also, just talking a little bit about PrEP access. I know I have 5 minutes, so I need to hurry along. That we have information on our website too. We're really trying to do a lot of work on educating healthcare providers on how to incorporate more HIV PrEP into their just general practice. I know that'll be a huge push in our next cooperative agreement from CDC, is that if anybody is coming in for an HIV sort of either testing or is at risk, that if you're negative, you leave with PrEP, and if you're positive, you leave with HIV treatment. That there's kind of there's kind of a medication provided at each of those visits. We have seen a lot of success for individuals who are on PrEP. One service that we do provide in our home test collection kits are all of the necessary labs for PrEP. And then that provider through telemedicine can also prescribe HIV PrEP to anybody across the state through that telemedicine component. Just wanted to talk a little bit here about the Rhine White Part B program. So it's a program that, again, really provides a comprehensive service to people who are living with HIV around their whole health needs. We're really ramping up our mental health offerings for people living with HIV. We do have a provider that's kind of really kind of more well-versed in kind of what that, what dealing with HIV and other mental health things is really about. We've also started some peer support groups and family support groups as well for people who have HIV. It's just kind of it can be a very lifelong and taxing disease to have. It's very stigmatizing as well, which we'd love to change. But there's a link here too. So in your practice, again, if you are seeing a new patient and they're talking about their HIV disease, or that comes up in conversation, just know that our Rhine White Part B program, which can be, again, you can click here and find out more information. We're really here to kind of wrap around that whole individual, not only with housing support, other financial support, insurance support, and all of those things as well. So it's an excellent service to be able to provide to people with HIV. I'm not really going to talk a whole lot about Hep C treatment because I got 2 minutes left here. We're working on it. There's not very many primary care providers that are willing to touch hepatitis C treatment, but it absolutely can be done in that primary care setting. So we're really working hard to kind of make sure that more providers are trained and comfortable providing Hep C treatment, because we definitely do have a lot of individuals who could benefit from that cure.
Interesting fact is that the ECHO model was first developed covering hepatitis C treatment.
It absolutely was. Yep, for sure. And it worked great. Works great. This just wanted to provide you here with kind of, I know it doesn't really line up here, but you can kind of see by the region that these individuals are. These are your, if you're in an area and you are seeing a patient that has any of these kind of sexual health needs, or has HIV or anything like that, these are really your local contacts. These are field investigators or field epidemiologists. They are going to be a great resource to refer those patients to. We're all kind of under one umbrella too. So, if a patient is reporting a reportable condition, that's required to be reported by law anyway. These are the people who you can report those to, and they can help kind of link and bridge them to other care. Just wanted to put this out here too. We do have a number of print materials, posters, other prevention supplies. Want to highlight condoms. If you want any of those in your practice, we will send them to you. And then we do have some more comprehensive guides for sexual health services for healthcare providers on how to kind of incorporate all this stuff into your practice. And then this is just my information. And I'm at time. So sorry, I left no time for questions.